Thank you, John. I see that people are trickling in. Hopefully, I know we have a big sign up, so hopefully a few more will be joining. I'm going to wait just a few seconds and then introduce our speaker.
Activity. Speakers cannot claim credit for their own presentations. Complete and submit the evaluation survey that will be emailed to you within 1 week of the offering.
Great. Welcome to the Department of Geriatric Medicine Grand Rounds. Before I introduce today's speaker, I have some housekeeping items. This CME activity is jointly provided by the Queen's Medical Center and UH Jabsom Department of Geriatric Medicine. As a reminder, evaluations are required for CMEs. You can find evaluations by following the link in the chat at the end of this talk, or in our email advertisement, or on our website. Your comments are very important to the planning committee and are used to plan future programs. All speakers are asked about potential conflicts of interest, and these are disclosed on the title slide. Today's speaker has no conflicts of interest with commercial enterprises. It's my great pleasure to introduce today's speaker. Dr. Susan Price was raised in Honolulu and received her medical degree from St. Louis University School of Medicine. She completed residency, chief residency, and geriatrics fellowship at Barnes Jewish Hospitals in Washington at Washington University School of Medicine. Prior to returning to Hawaii in 2018, she served for 20 years as a medical director in the Division of Geriatrics and Extended Care at the Palo Alto VA Medical Center and as a clinical instructor at Stanford Medical School. She joined the Hawaii Pacific Health Geriatrics team in 2019 and became division chief in 2022. Her current focus is what she's going to be talking about today, directing the GUIDE program, a CMS-funded project to develop a model of dementia care. Please join me in welcoming Dr. Susan Price.
Thank you, Kamal. Oops. John, I might need your help. There we go. Okay, so today I'm going to talk about GUIDE. So we'll talk about what it is, why it was created, who's eligible, some unique features, and finally, what we've learned and what we plan to do now. So first of all, what is GUIDE? As you know from the title of our talk, it stands for Guiding an Improved Dementia Experience. It's a CMS-funded 8-year study of a new model of care delivery for people living with dementia. It's a CMS innovation project similar to primary care. The goal of GUIDE is to develop a sustainable, accessible, affordable, evidence-based dementia care delivery model. It also tests whether this dementia care model will improve quality of life and enable people with dementia to remain in their homes longer. And it incorporates best practices from established dementia care groups. Right now, there are more than 300 GUIDE programs nationwide in 44 states, and there are about 200,000 patients enrolled at the moment. The first program started in 2024, and the second group started in July 2025 after a 1-year implementation period. Straub-Benioff is part of that second group, and we're the only GUIDE program in Hawaii. The application was submitted in 2023 by Dr. Huidi Shu, so I want to give him a shout out. We started enrolling patients 1st of July. And right now, our staff for Guide includes 3 geriatricians, 1 social worker, and our fantastic geriatrics clinic staff. So who's eligible for Guide? Guide is for Medicare beneficiaries with a diagnosis of dementia. They have to have Medicare Parts A and B. They cannot be enrolled in a Medicare Advantage plan. They cannot be enrolled in hospice, and they cannot be living in a skilled nursing facility. They can be living in assisted living facilities and care homes, etc., but not in a skilled nursing facility. They also must reside in a designated zip code. We designated all of Oahu, so currently we're seeing patients on Oahu, but we expect to expand to other islands next year. So there are 5 main special features of Guide listed here. First of all, I'd like to go through the payment methodology. We get paid not fee for service for these patients, but we submit a dementia care monthly payment every month that we see the person. This is not automatic. We must interact with the patient, but it does not require a clinic visit or an official appointment. The reimbursement or the dementia care monthly payment varies by patient tier. We'll talk about that later. And the payments are higher for the first 6 months of enrollment, and then they drop down significantly for the rest of the study. Comprehensive assessment is another requirement of Guide. We do the usual things that we do in our geriatric assessment clinic: cognitive testing, functional assessment, medication review, and advanced care planning. But Guide also requires caregiver assessment, a quality of life measure for patients, a socioeconomic assessment, and a dementia severity rating. For cognitive testing, we've used the mini mental status exam, the SLUMS. I use the short blessed for phone visits and video visits, which I find works well. And we do a geriatric depression screen. Functional assessment, looking at ADLs and IADLs as per our usual assessments. Medication review and reconciliation. That will be more of a focus for the 2nd year of our program. And advanced care planning, as we do routinely. The caregiver assessment is something we have not routinely done. And this includes getting the demographics for the caregiver, the primary caregiver, including their age, whether they have Medicare or not, whether they live with the patient, and how long they've been doing the caregiving. If they are on Medicare, they give us their Medicare number, and Guide is following their health status as well. We also look at caregiver burden using the Geriatric burden inventory, which I don't know if you can read that, but it's a scale of 0 to 4, really asking about emotions attached with caregiving, let's see, so are you stressed between caring for your relative and trying to meet other responsibilities? Do you feel strained around them? Do you feel like you've lost control of your life since your relative's interest? And so forth. So the higher the score, the higher the caregiver burden. Okay. We also obtain a quality of life measure for the patient. And this is using the PROMIS 10. There are a variety of different PROMIS scales. This is for global health. And it's a 1 to 5 scale. asking about how a patient rates their health, quality of life, physical health, mental health, their social activities and relationships, how well they can carry out their usual roles and their usual physical activities, and how often they've been bothered by emotional problems, how bad their fatigue is, and if they have pain, how severe their pain is. Interestingly, we've had problems with doing this test with our patients. Everybody tends to feel that their memory is fine and they're doing fine. So, but we're required to have this as part of enrolling them in GUIDE. So, but I think this is going to be, a problem to interpret in the future. The GUIDE also requires a specific socioeconomic assessment, which we have not started using. There's the PREPARE test, test that we have not used. That should be in the second year. And finally, we assign a dementia severity rating using either the FAST or the CDR. The functional assessment screening tool is the one that I tend to use the most because it's pretty straightforward and it's more nuanced than the clinical dementia rating. And also, this is the scale that our hospice agencies use. So this goes from a 1, which is normal aging, to stage 7F, which is severe dementia. The clinical dementia rating from Washington University is listed here. In order to do this properly, one is supposed to execute a specific interview, a structured interview, which we do not do, but can usually, fill in the blanks here based on our history. But this does not capture people that are kind of in between stages. So after the patient is assessed, then they are aligned. And by alignment, the process is that their data is submitted to CMS by means of a patient assessment and alignment form. This form includes patient data, their demographics, including their ethnicity, where they live, what kind of place they live, their Medicare number, their dementia stage, and their PROMIS 10 score. The caregiver data is also entered here, including the same demographics, their Medicare number, and their Zaret burden interview score. And then finally, a dementia qualified physician has to attest that the person has a dementia diagnosis. So the 3 geriatricians on our team are all dementia certified providers, so we can make those attestations. After the data is submitted and reviewed, the patient is accepted or rejected. So far, we haven't had anybody rejected out of hand. There have been glitches with numbers and so forth, but everybody has been aligned. And GUIDE assigns the patient to one of 5 tiers. Oops. Sorry. Based on the severity of dementia, the presence of a caregiver, and whether the caregiver lives with them or not, and caregiver burden. So the 5 GUIDE tiers is divided into dyads, which are patients who have a caregiver, and individual tiers who do not have a caregiver. So far, we have not enrolled any individual tier patients. And the GUIDE tiers are relevant because that also dictates how much we get paid to see them, where the higher complexity dyads bring in, more than double the low complexity dyad tiers. And after the first 6 months, as I mentioned, these reimbursements drop down significantly. The third new feature of Guide is care navigation with regular follow-up. So the center of our team is our care navigator. A care navigator can be a social worker, a community health worker, a nurse practitioner, physician, even a trained layperson. In our case, we have a social worker, Tracy Romualdo, who's joined our team. The care navigators must have required dementia training and experience working with people with dementia. The care navigator performs a home visit within 60 days of the initial assessment, and they come up with a care plan. They are also the center of the caregiver education and support, coordinating care, connecting people to resources. And finally, there is specific follow-up required by Guide, monthly for the higher dyad tiers, which can be done by phone or telehealth, and quarterly follow-ups for the lower tiers, which can be actually done by email, phone, or telehealth. In order to get paid, we have to see patients, so we've been trying to catch them once a month, regardless of tier. Fourth, Guide requires access to a dementia care team member 24 hours a day. So during working hours, those calls are taken by Geriatric's clinic, and after hours by an on-call provider. So far, we have not had anybody call after hours. And finally, the piece that has the most interest in the public is respite care, which is attached to Guide. You may see ads like this on Facebook or other social media. I've seen about 3 organizations advertising that way. So it's true that Guide patients in the higher tiers, the moderate to severe, are provided with about $2,500 per calendar year to help pay for respite care. In Hawaii, it's a little bit more than that. Respite care includes home care, day care, and inpatient respite care. The care must be delivered by Guide partner organizations. And we have partnered with a number of agencies in the community, home health agencies, daycare, and some agencies that provide inpatient care. And payments are made from CMS through Straub to the partners, so we act as a pass-through. And the CMS pays a specified amount for these services. So home care is $141 for a 4-hour increment. Daycare is $107 for an 8-hour increment, and inpatient respite is about $329. So that doesn't go very far. The home care and daycare reimbursement rates are actually in line with most of our agencies charge. The home health being a little bit cheaper than what they charge. And then Guide proceeds with specified follow-up intervals. We're required to reassess patients once a year, and if there's a clinical change. And patients may move between one tier to another. And Guide is continuing until 2032. So what have we learned in the first 5 months? We've assessed more than 100 patients. Actually, it's more than 104 at this time. We've been focusing on our geriatrics clinic patients because they are a captive audience. Right now, we have 94 patients currently aligned, and 40 of them are in the moderate high tiers. We've lost a number of patients due to hospice admission and moving out of state, and one person is in a nursing home getting rehabilitation, so we've disaligned her. And we've had several patients who we didn't even submit to CMS, we just referred to hospice directly. Follow-up has been getting very busy, and this really demonstrates the advantage of the payment methodology, where we can make a phone call and get paid for that month's dementia care, which is not something you can do in a fee-for-service model. There are challenges with respite care. We are finally getting that going with some patients, but it's been interesting getting the contracts in place and so forth. But there's a very high interest from our partner organizations. And finally, really the most interesting thing to me at all, or the most rewarding thing, is the community connections that we've developed because of the guide program. And we've met many people that we did not work with before, and that's been very rewarding. So in the next 7 months, our goal is to have 200 patients aligned. We need to expand our team in order to do that. It's really the care navigators that are the limiting factor. We also hope to implement caregiver education and support groups, and I'd look to developing a better assessment of caregiver preparedness and buy-in. We're hoping to expand to Kauai. Right now, we are in the process of getting their partner organizations lined up. We continue to improve our processes. We've already adjusted things several times since July, and we're hoping to streamline things like data collection, patient tracking, and so forth with the help of IT. Right now, we've been maintaining things on spreadsheets by hand. So to refer a patient to guide, first of all, you must confirm eligibility. So the person must have dementia. We're not assessing people with possible dementia. Must verify that they have both Medicare A and B and not an Advantage plan, which can be difficult because a lot of the Advantage plans are not labeled as such. And there are quite a few patients on Medicare Advantage plans in Hawaii. The patient can't be in hospice or in a skilled nursing facility. To refer the patient, just place a geriatrics consult indicating that it's for guide, and they will be assessed separately from our routine consults. And just a disclaimer that because of staffing issues, we've been prioritizing our current patients from geriatrics and neurology, as well as PCP referred patients and then external patients. We have seen a number of external patients who come in through geriatrics or neurology clinic, but it's just logistically harder communicating with the PCP and so forth. If you want to learn more about Guide, there's a CMS link. You can learn everything you want to know about Guide, or feel free to email me if you have any questions about the program. And that's it for my presentation. It went pretty fast today. Does anybody have questions?
Susan, thank you so much for a very informative session. Let's open it up for questions. Anyone from the audience, please unmute yourself, or if you prefer, you can also put it in the chat. I'll monitor the chat. But please feel free to unmute yourself and ask your question. Cody has a question. Go ahead, Cody.
Hi, Dr. Price. I'm Cody. I'm one of the geriatric faculty that does nursing home medicine. I was wondering about, if you do have patients in your program, and they are hospitalized and then end up SNF or rehab, like you might have mentioned, like maybe one case. Once they're discharged from SNF rehab, do they have to go through the whole process to become aligned again, or can you just pick them up, like the off-on Medicare coverage?
Yes, yeah. So the person that we disaligned in that circumstance was somebody that we were referring to hospice simultaneously. So we just took her out of the roster. We currently have 2 Guide patients in rehab facilities, and so we've left them and plan to follow up as per the normal protocol.
Okay, so they don't get kicked
They
off
don't
the
get kicked
program.
out
They just...
immediately, right?
I
Yeah.
see. Okay, thank you.
So they can't live in a nursing home, but
okay.
a short
As long as
stay
it's
is
not long-term
different.
care.
Yeah.
Thank you.
Jordan Gardner has a question. Jordan, would you like to unmute yourself?
Okay.
Go ahead.
Okay.
Yes.
So my question was really just related to the variety of presentations of dementia that are involved in your program. There was a lot of mention of difficulties with memory, which makes you think of Alzheimer's. But are you also taking things like behavioral variant frontal temporal dementia and posterior cortical atrophy? A very, very broad range of presentations, which obviously would then really impact patient needs.
Right. So we are taking all types of dementia, and the more behavior problems there are, the higher the tier that they'll be in. So yes, we're taking all comers.
Appreciate it. Thank you.
Lauren has a question. Lauren, you want to unmute yourself?
Oh, hi, Dr. Price. Sorry.
Hi, Lauren.
Hey, are we allowed, sometimes we have clinics in like AL or IL. Is that like off limits because it's attached to like a nursing facility is in that building, or are we eligible to like have a program like this in those clinics? Do you know?
Can you have a clinic like a Guide program?
Yeah, like you say there's a clinic in a assisted living or independent living community, like let's say an Arcadia or something, and they have a clinic. It's not a nursing home,
right,
but a clinic. Can this program be
so
allowed there?
People living in assisted living facilities, even care homes, can be enrolled in Guide. And the caregiver for a person who's listed, who's living in a care home, is actually the person that helps with IADLs. So it would be the family member and not the employed caregiver. So it's a non-employed person who's helping the patient.
Oh, cool. Thank you. Thanks, that clarifies it.
Any more questions, anyone?
Hello.
Susan? Oh, sorry, go ahead.
Hi there. This is Louise Iwaishi.
Hi.
Hi, Louise.
Hi, Dr. Muscat. Hi, Dr. Price. My question is, there's been such a push by all the major health insurances to automatically assume that once you reach age, everybody gets, and there's even advertisements on how to pick the best Advantage program. And I know
Mhm.
there's a lot of national controversy as to what is going on with these organizations. Now, CMS is supporting this effort on Guide, and I was with the Maternal Health Bureau as well, locally as well as nationally, in terms of understanding how to get the best for our seniors. And I guess, I'm now caregiving, believe me, I'm a pediatrician, now
Mhm.
caregiving for my 100-year-old mother. And I
Wow.
must say, as I'm listening to Dr. Masaki and the geriatric, I'm amazed at how the spectrum, is. But my question is CMS attempting to create a a product of itself for people who are not enrolled in any because these advantage programs are so rich, but they are so costly for the organization. And the controversy that I'm aware of nationally is that this is a big ripoff, because we know that Part A and even Part B is highly funded by Medicare. It's
Right.
the C, D, E, all the extra. But just a quick thought in your mind, because I know nationally, there's all this controversy about just how our leadership is going. But I'm hopeful that CMS and Medicare is looking at the vulnerable population, and not the big pharma people who are, I swear it's crazy.
Yeah. So Medicare Advantage plans have run out of favor among some people. They can be more restricting for patients, and sometimes the premiums are higher, prior authorizations are hassle, and so forth. So regular Medicare is actually felt to be better, including the fact that you can enroll with Guide. And we've had patients who are wanting to change their Medicare enrollment so that they can participate in Guide. The Medicare Advantage programs do include a certain amount of case management, but it's not as structured or robust as the Guide program.
Okay. No, I appreciated that. It's just it's a terrible time to be a survivor. Let me tell you, this country has been very strange. But thank you, because I feel like even from pediatrics and so many of the organizational advocacy has come from the experts and the families. Always,
Right.
it's always. But thank you, Dr. Price, and thank you, Dr. Masaki, always for being at the leading edge. Thank you very much.
Thanks.
Aloha. Bye bye.
Thank you, Louise. I think we have another question from Marina, one of our clinic physicians from Queens. Marina, do you want to unmute and ask your question?
Hi, sorry. I was eating my lunch. Yeah, I was just kind of curious, like when we say that the navigator has to have some kind of dementia training or education, like what that really means. I think we've either there is or was like a REACH program at some point, like because so much of the dementia behavior stuff is really like non-medication strategies, and that's the part that like requires a lot of hand holding and time and education. And to me, that's where I see like a lot of need in our clinic is just somebody who can do that education. But getting that education is also, I think, hard. So I was just curious if they like had a criteria for like what training was required.
There are specific requirements, and there are approved training programs, such as provided by Dementia Care Aware, UCSF. There are various programs that are accepted by Guide as training. Um, that doesn't mean the care navigator is necessarily an expert in behavior management, but that's where the physicians come in, and we're hoping to have um, private sort of lectures and support groups for our caregivers to help teach them how to manage the behaviors. We're also partnering with the Positive Approach to Care, and so we'll have them come and speak to our caregivers as well.
So Susan, are you saying you're planning like a caregiver training series kind of
Yeah,
thing?
yeah.
Oh, awesome.
So sorry, Dr. Price. One quickie question.
Mhm.
Have you heard of the Switch program, which I'm sure you're familiar with? The team-based, Dr. Masaki, the Switch program. And I'm just wondering because it was highly evolved to be team care, tiered, and etc. So just wondering, is this sort of what Guide is also offering?
Yes and no. And to answer your previous question, they are trying to create a product, just a model for how dementia care should occur, and trying to figure out what resources are needed in order to do that.
Okay, thank you so much. I
Mhm.
just wondered because it was evolved to be allow the geriatricians, to do their work and the PCPs to be highly functional with all those supportive, very significant other family and paraprofessionals, to work to their capacity or
Right.
licensing. Thank you again. Sorry. Okay.
Susan, do you know of any reports from other national sites of the guide about how things are going?
We attend an affinity group out of UCLA who they were one of the first guide programs, and they contributed, like the respite care payment came out of their practice as a way to reduce the barrier to somebody trying daycare or a home health aide, for example. So we do attend meetings twice a month with UCLA. And then there's a community online of guide programs. So we share our practices and problems with one another. I think it's been going pretty well, but it's a very diverse group of participants, all the way from a huge program like UCLA down to very small programs. Many are home health agencies or hospice agencies that are guide participants. So very wide variation.
And then do you have a target number of patients you're hoping to enroll?
Well, we're supposed to enroll 200 in the first year, and we're required to maintain 200. But I think we could continue to enroll people as long as we have the staff. And the physician staff is not the limiting factor at this time. It's really the care navigators.
And how many do you have enrolled so far?
We have 94.
Oh, wow.
Yeah. So we were initially worried about recruitment, but we kind of figured out a process, and we were able to enroll about 75 patients in October and November. So we've had to slow down in order to complete our follow-ups.
Any more questions, anyone?
Are you saying that you're having not enough care navigators?
Yes, we need to hire more care navigators.
And you're specifically wanting social workers?
Right now, we are looking for a community health worker. So we have a job posting for that. And we may create a nurse care nav position.
Aida, I think you had a question.
Yeah, actually, that's exactly what I was going to ask. I was asking about, so is this care navigator a CHW, and if, if we maybe we're working with KCC and their CHW program a little bit, and if there's stuff that you think specifically they should have in their program, maybe we can talk about that.
That's a
Create
good
that
point. Yeah, we've interviewed a couple of people from there, but neither one had really any significant training or experience in dementia care.
Right, because they're thinking about doing like, certificate little, programs and things like that. So I'm
Right.
kind of wondering if you could put together a wish list and we can see if that's something we can
Yeah,
build.
that's a good idea.
Susan, we work with the KCC and other community colleges too through our GWEP grant. It's a HRSA grant about workforce development in geriatrics. And so this would fit right in.
Good.
Any other questions from anyone?
I have a question. Hi, Dr. Price.
Hi,
Dr.
Michelle.
Masala. About the expansion in Kauai, what are the plans? What are you thinking, the thoughts for Kauai?
Well, we have a clinic on Kauai at Wilcox,
Mhm.
so we've been over to meet everybody. And there's a very motivated Alzheimer's Association person on Kauai who's helped connect us with partner groups. So we just have to interview the partners and get them to sign on. But we've sort of tabled that until next year.
Okay, but you'll be managing the patients and then using the resources, the connection. Okay,
Yeah,
perfect.
our local leave. Yeah, because
Okay.
we can do care by telehealth.
Right. Okay.
And there are geriatricians on Kauai.
Right.
Yeah.
I just had a meeting with the Wilcox group and they're like, well, whatever support Dr. Price needs in the team, let us know. So just a FYI, because I just shared about the guide and they were like pretty impressed about your data.
Yeah.
Thanks.
Hawaii is lucky. There are several geriatricians on Kauai. It's one of the lucky islands.
Yes.
Okay, any more questions, anyone, or comments? If not, thank you so much, Susan. Again, very interesting presentation. You can see that there's a lot of interest in the community by the amount of people that showed up and that asked questions. For the folks online, if you want CME, don't forget you do need to do an evaluation to get CME. John, thank you for putting the link into the chat. So you can use that link to go to the evaluation form, or it's on our invitation as well. Thank you all again. Hope you all have a very happy holidays. And thank you again, Dr. Price, to you and the partners for providing this really wonderful program for the people of Hawaii.
Thank you.
Thanks, everyone. See you all in January. Have a happy holidays.